Today's webinar topic will be on the prevalence of early post-thyroidectomy complications and associated factors at Tzna General Hospital in Addis. The presenter will be Dr. Tesfaye Gasho. He's a medical doctor and public health specialist. Our reviewers will be from the clinical part, Dr. Ndala. I'm sure you all know him. He's a senior endocrine surgeon at Addis Ababa University College of Health Science with ample experience in the clinical field, as well as a research enthusiast senior. Glad to have you with us, Dr. Ndala.
Thank you.
Thank you. And for the research methodology part and other research undertaking part, I'll take the review process. Welcome everyone again. Dr. Tesfaye, you can start the presentation. You can take 15 to 20 minutes for presentation, and we'll proceed with the suggestions from the reviewers and the audience. Thank you.
Thank you, everyone. Can you hear me? Hello? Can everybody hear me?
Your sound is a bit distant, Tesfaye.
How about now?
It is better, but I think you can raise the volume of your PC, I guess.
Okay.
If you are ready, you can start.
Yes, I'm ready.
Okay.
Okay, good evening, everyone. Thank you for the presentation. My name is Dr. Tesfaye Gasho. I'm a medical doctor by profession, and this is my thesis on the prevalence of early post-thyroidectomy complication and associated factors at Tzna General Hospital as part of the partial fulfillment for MPH program. My slides are quite a lot, so I'll try to finish it as fast as possible, and we'll discuss it afterwards if there's any question. Okay. As an introduction, we all know that goiter is defined as any enlargement of the thyroid gland, which normally produces hormones that regulate various metabolic activities in the body. And it's one of the most common endocrine system diseases worldwide, with an estimated global goiter prevalence rate of 15.8%. And it's endemic in most developing countries, including Ethiopia. There are different reasons for goiter to occur or thyroid swelling to occur, which can be due to either physiological or pathologic changes, which include iodine deficiency, which is the most common in our setup, autoimmune disorders, intake of goitrogens, tumors, inborn errors, radiations, and infections can also cause enlargement of the thyroid gland. And mostly goiter presents as an incidental finding or as a swelling of the neck observed by patients or others, and imaging studies done for adjacent structures. But patients also present with a rapidly increasing swelling with compression symptoms like difficulty swallowing, voice changes, stridor, pain, and signs and symptoms of hyper or hypothyroidism. And management of such disease includes medical treatments for hyperthyroidism or hypothyroidism, including propylthiouracil or levothyroxine supplementation, and surgical treatment with thyroidectomy, which is an operation involving the surgical removal of all or part of the thyroid gland. It's one of the most commonly performed surgical procedures worldwide. And in our country, there are also multiple studies and clinical audits showing that goiter is the most common cause for elective general surgical admissions. And as part of the Essential Health Service Package in Ethiopia 2019, the thyroidectomy is classified under the non-trauma surgical conditions to be provided in general and tertiary level hospitals with medium priority given. Complications associated with thyroidectomy, just like other surgical procedures, are decreasing in frequency throughout the years compared to its early beginnings, where around 40% mortality were reported, and mainly due to infections and hemorrhages. And yet, still it's associated with complications like respiratory obstructions, recurrent laryngeal nerve injury, hypocalcemia, hypothyroidism, hypoparathyroidism, seroma, hematoma, and thyroid stone, with an overall complication rates around 11.2%. Identified risk factors for such complications included age, gender, type of thyroid disease, type of surgical procedure, coital recurrence, and weight of the thyroid gland. And most of these complications can be prevented with appropriate quality measures. When coming to the rationale of the study, we all know that surgical care quality can be assessed using structure, process, and outcome as metrics to further devise improvement measures, which will have impact in the post-operative care and patient quality of life. And furthermore, collecting and analyzing procedure-specific outcomes and institution-related comparisons will help produce a national quality improvement metrics, which will help the healthcare system as a whole. In this regard, studies on post-thyroidectomy outcomes are minimal in our study and are limited to public hospitals to the best of my knowledge and my literature review. They also lack to implement measures of association between the outcome and possible factors associated. So this study aims at narrowing this gap on data regarding outcomes of surgical treatments of goiter in private hospitals with comparable disease burden and possibly identify major factors for procedure-specific complications. The study context, the study was conducted in Addis Ababa, Ethiopia, in the surgical wards of the Tzna General Hospital. The Tzna General Hospital is one of the pioneer privately owned general hospitals with more than 20 years experience in medical and surgical treatment of patients, and staffed with multiple specialists and subspecialist medical doctors and nurses, and provides major surgical services like general, cardiothoracic, orthopedic, and multiple disciplines. Here's my conceptual framework regarding the cause for post-thyroidectomy complications. I tried to assess the social demographic factors, the illness factors, such as previous comorbidity and thyroid recurrence, and the disease factors, such as duration of symptoms, medical treatment for goiter, previous thyroid surgery, and histopathologic type. I also included procedure-specific factors, such as type of procedures, as a possible factor causing early post-thyroidectomy complication. And when I come to the objective, the general objective of this research is to determine the prevalence and associated factors of early post-thyroidectomy complications in Tzna General Hospital, Addis Ababa, Ethiopia, and specifically to determine the prevalence as well as identified factors associated with early post-thyroidectomy complications. And when we come to the method, the study design is an institution-based retrospective cross-sectional study conducted between October 2016 and October 2022 using medical chart of patients who were admitted with the diagnosis of goiter and underwent thyroidectomy. My source population and study population are similar, which is all patients who were diagnosed to have goiter and underwent thyroidectomy in the specified time at the Tzna General Hospital. And my inclusion criteria was patients who were admitted at the hospital with the diagnosis of goiter and have undergone any form of thyroidectomy between the time period of 2016 and 2022. And exclusion criteria were patients who were mislabeled, who had mislabeled data, patients' data missing more than 50% of the study variables and admitted with the diagnosis of goiter but did not undergo thyroidectomy. Patients who had previous neck surgery with the possibility of complications and previous parathyroid disease, history of dysphonia, chronic kidney disease were excluded. Sample size calculation using single population proportion formula with a margin of error of 2% and confidence interval of 95% and prevalence of post-thyroidectomy complication 11.2% from previous study. And after adjusting with finite population correction and considering 20% incomplete data, calculated sample size became 304. And sample size was then calculated for the specific objectives using double population proportion formula using EP-info for significantly associated factors from different literatures, previous literatures, which were all less than the single population sample size, so they were dropped. And finally, the calculated sample size was almost equivalent with the total number of patients who underwent the thyroidectomy over the stipulated periods, which is around 345 patients. So I decided to include all the patients within the time frame. The data collection instrument was a self-developed data extraction format using study variables, which are measurable in this study context from similar studies previously, both local and international. And the data collector was a health officer from the institution itself who had adequate knowledge about the study area during weekends, not interfering with her work schedules. During the data collection procedure included the proper training on specific data collection procedure, handling of incomplete charts, keeping confidentiality, and time management. And the appropriateness of the data extraction format was pre-tested on around 30 medical charts, around 10%, with 5 charts randomly selected from each year and checked for the appropriateness of the methodologies followed. And all patient charts were, when the pre-test was done, were also included in the study, and the data was collected over a period of 10 weeks. When we come to the data processing, the collected data was coded and entered through data entry format created using APinfo, and the data was cleaned and exported to Spaces version 26. Both of the data entry and cleaning were done by the principal investigator. When we come to the data analysis procedure, univariable analysis was conducted for individual variables through ways which are mostly descriptive for categorical data, using frequency, and continuous data using measures of central tendencies such as mean, median, and mode, and measures of dispersion. And bivariable analysis was then performed to assess the presence or absence of significant association between the dependent variables, which is presence or absence of early post-thyroidectomy complication, and which is dichotomous, and each independent variable separately: the gender, age, type of thyroidectomy, presence of comorbidity, duration of presenting symptoms, which were all coded to a categorical value using chi-square test. The p-value of each test was evaluated for significance, and those with less than 0.05 were considered significant after assumptions were checked whether it was violated or not. And finally, multivariable analysis was done to evaluate the effect of the independent factors on early post-thyroidectomy complications using binary logistic regression. After multi-collinearity assumptions, statistical significance and fitness of model was checked. When I come to my operational definitions, these are my operational definitions. Early post-thyroidectomy complications are complications arising after surgical removal of the thyroid gland, and starting from immediate post-op death up to 6 months, and surgical site infections are infections that up to 7 days after surgery in part of the body where the surgery took place. That is the neck in our study. And hypothyroidism was assessed using the WHO criteria, where a condition having a normal T3 and T4 level less than normal, and TSH level greater than 4.5 milliliter unit per liter, and resulting in symptoms of decreased appetite, cold intolerance, muscle pain, and in severe forms coma. And hyperthyroidism with TSH level less than 0.4 milliliter unit per liter, and total T4 greater than 12 microgram per deciliter. And hypocalcemia defined as a total serum calcium concentration less than 8.8 milligram per deciliter, and serum progressive increase in mass or lump caused by a buildup of clear fluid at the surgical site over the first 2 weeks of post-operative period. The ethical considerations after approval for research proposal was gained from my advisor and at this Continental Institute of Public Health ethical review board. Data collection approval was then asked for and obtained from Addis Ababa Regional Health Bureau and the Tzna General Hospital. Then patient charts were collected from the hospital logbook using admission charts number and phone number, which is currently used in the electronic medical system. And using the data extraction format, all the necessary information was gathered, and the collected data was safely stored by the principal investigator. After giving them unique ID, each patient's data was entered into APinfo 7.2 generated data extraction format without using patient's name or phone number for further analysis work. And finally, we come to the results and discussion part. So during the study period, a total of 2,778 elective and emergency surgical procedures were done, and the thyroid surgery accounted for 10.7%, which is 298. As I said before, the sample size I took was 345 patients. Out of those were admitted with the diagnosis of the name goiter at the hospital logbook. Out of this, 35 had other diagnosis and were mislabeled as goiter, and 12 were admitted for other diagnosis having goiter as a comorbidity and did not undergo thyroidectomy, and they were excluded, and 20 had missing data, more than 50%, and they were also excluded, and 278 patients were analyzed, out of which 37 were men and 241 were female, around 86.7%, having a female to male ratio of 6.5 to 1. The female predominance and the percentage is comparative with other hospitals in Ethiopia, where similar studies were done. And also the thyroid surgery prevalence was also comparable, where at the Audit Hospital around 7 to 23% of the surgical admissions were thyroidectomy admissions, and at St. Paul Hospital around 11%. The female to male predominance is also comparable, as I said before, with the similar study done in Gondar showing a ratio of 5.22 and at the Audit Hospital 6.6 to 1. The normality was checked, the median was taken as a measure of central tendency because it was not normally distributed, and with a median age of 43.1 and the minimum age being 17 years and maximum age 8 years. More than half of the patients resided in Addis Ababa, out of which out of the 278 patients, 29.5% of the patients had at least one or more comorbidities, and 7.2% had retrostomal goiter. 7.8% of the patients were on medical treatment for goiter before the surgery, and 7.9% of the patients had previous thyroid surgery presenting with goiter recurrence. This is basically what I said before. It's 6.7% female predominance, and the 35 to 50 age group was the most common age, and most of them resided in Addis Ababa. And anterior neck swelling was the most common presenting symptom, followed by rapidly growing swelling with pain and symptoms of hyperthyroidism, cosmetic purpose, and difficulty respectively. The duration of presenting symptoms ranged between 1 to 5 years in majority of the patients, and half of the patients had normal thyroid function tests preoperatively, while 34.5% had hyperthyroidism and 15% had hypothyroidism preoperatively. Most common performed surgical procedure was subtotal thyroidectomy and near total thyroidectomy, while the least common ones included thyroid lobectomy and lobectomy with hysterectomy. Post-operative histopathologic examination was done on 231 patients out of the 278, indicating nodular goiter being the most common histopathologic type, and according to different literatures, benign thyroid diseases are the more common than malignancies, while chronic goiter is the most common thyroid disease in the world. Follicular and papillary thyroid disease were the most common thyroid malignancies, each of them accounting for 7.9%. The average hospital stay was 3 to 7 days, around 93%, and 4 patients stayed longer than 7 days due to complications requiring tracheostomy. There were no days encountered, and 17 patients required intraoperative blood transfusion. This is a histopathologic type of patients who underwent thyroidectomy, showing that goiter being the most common type, and from the thyroid malignancies, follicular and papillary thyroid cell, each accounting for 7.9%. And a total of 121 patients developed one or more early post-thyroidectomy complication during the study period, and female accounting for more than 90% of the patients. Most frequently encountered complication being hypothyroidism, accounting for 38.4%, and followed by seroma, then hypocalcemia, and superior thyroid, respectively. Further bivariable analysis was then done to assess the presence or absence of significant association using chi-square test between the dependent variable, which is dichotomous presence or absence of early post-thyroidectomy complication, and the independent variables listed below, and those with p-values less than 0.05 were considered to be significant after assumption was checked. These are the bivariate analysis and p-value results: gender, type of thyroidectomy, histopathologic type, and previous thyroid surgery were shown to have significant associations. Those with significant association was then further analyzed using multivariable analysis, which is biologistic regression, to examine the degree of the strength of association. After preliminary analysis using linear regression suggested the assumption of multicollinearity was met, and the statistical significance of the model was also achieved. Finally, in Hosmer's and Lemshow test was done to check whether the model was fit or not, with a p-value greater than 0.05, and the model correctly classified around 69.3% of the cases. These are my multivariable analysis results with p-values less than 0.05 shown with the bold notes. And with this, to the gender, the male host ratio was 0.026, suggesting that the men are 0.26 times less likely to develop post-thyroidectomy complication compared to their female counterparts. And when we come to the type of thyroidectomy, patients who underwent thyroid lobectomy with hysterectomy were 0.1 times less likely to develop early post-thyroidectomy complications compared to the total thyroidectomy, which was associated with 81% complication rate. And lastly, when we come to the histopathologic type, follicular thyroid cell was found to have significant association with patients with follicular thyroid carcinoma 7.9 times more likely to develop early post-thyroidectomy complication compared to patients with other histopathologic types. And here with adjusted odds ratio, the confidence interval is quite wide. I will try to explain this by, because follicular thyroid was a smaller in amount in the number of patients who developed complications. And additionally, 50% of the patients with follicular thyroid underwent total thyroidectomy. As I said before, total thyroidectomy was associated with 81% complication rate in our study. When I come to the discussion, I tried to discuss some of it with the results, but the leftover ones, overall 121 patients developed early post-thyroidectomy complication, the most common being hypothyroidism, and half of which was transient, not requiring treatment. Even though multiple studies report hypocalcemia to be the most common complications, our study findings can be explained by the fact that a major type of procedure practice was subtotal thyroidectomy rather than total thyroidectomy, which is associated with which is practiced elsewhere for reasons like malignancy treatment, recurrence prevention, but increasingly associated with accidental injury removal and devascularization of the parathyroid gland, leading to hypocalcemia. And additionally, risk factors for hypothyroidism include seropositive thyroid peroxidase antibodies, high normal preoperative TSH levels, and histopathologic confirmed thyroiditis. In our study, 15.1% of the patients had hypothyroidism before surgery, increasing the number of post-thyroidectomy hypothyroidism and constituting 33% of the total number of patients who have hypothyroidism postoperatively and requiring thyroid hormone replacement. There are also major differences regarding the post-thyroidectomy complication rate and types while comparing our study with similar studies done in public hospitals such as St. Paul, having a complication rate of 8.1% and hypocalcemia being the most common complication, while in Gondar having 5.7% complication rate and hemorrhage being the most common complication. Finally, when I come to the strengths of this study, the study tried to show the private hospital perspective regarding procedure-specific outcome and possible associated factors for complications after thyroid surgery. And it also tried to find association between early post-thyroidectomy complication and multiple significant factors besides only describing their prevalence. The limitations, the major limitation being only a single institution-based study, making it difficult to generalize, and it was also difficult to ascertain whether some complications were really transitory because long-term follow-up was quite poor and there were data. And some of the post-operative complications like superior laryngeal are being diagnosed clinically, which is not subjective. In conclusion, this study has found that surgical thyroid disease is more prevalent among women and post-thyroidectomy complications are significantly associated with gender, type of procedure, and histopathology. And despite having comparable demographic distribution in the disease burden, there is a significant difference in type and prevalence of post-thyroidectomy complications among public and private hospitals. And I recommend that this study shows the need for further population-based multi-center and comparative studies, which are necessary in order to assess the strengths and weakness of multiple surgical centers, find gaps, share experience, and support each other, and also create a national outcome-based surgical care quality metrics, surgical treatment of goiter, which could play a vital role in developing quality of care and decreasing morbidity and mortality. Finally, I would like to thank my school at Continental Institute of Public Health and my research advisor, Ms. Hannah Kolman. I also would like to thank the Tzna General Hospital for allowing me to conduct the research and Ms. Wanshet Varega for my data collector. And finally, Medical Research Lab for the opportunity to present and learn. Thank you.
Thank you very much, Dr. Tesfaye, for the presentation. Dr. Ndala, you can start suggesting and forwarding your opinions. Over to you.
Okay, thanking one question. What was the follow-up after Hello? Hello?
Can you hear him well?
Hello?
Or just
No,
me?
I did not hear the questions.
Okay. I think, Dr. Ndala, you can repeat your question.
Yeah.
It was not audible. Okay.
Yes. What was the median duration of patients after surgery before one?
I'm sorry, the quality is quite poor. I'm not really getting the full questions. Is it just me or?
It seems like he has a connection problem. Let's wait for him just a bit. Dr. Ndala, you're back, I guess.
Thank you very much. And I wanted to acknowledge Dr. Tesfaye for his very important clinical part. research, and it's very important topics for me. So saying this one is also a good presenter, and it's short and precise. If I wanted to jump to my comment, I think the study design was a retrospective cross-sectional study design, and I have seen the sample size determined. It was 345, but I'm not clear with how sampling procedure was take over, because it was a wide time frame starting from the 2060 to 2090. So it is very broad. It is very broad. So our sampling procedure was carried out. And the other is, for you also conduct is a bivariate analysis using chi-square. So why not? So how the multivariate variable is selected? So how the multivariate variable is selected in the binary logistic regression? So why the chi-square or crosstab is needed for that one? And the other is, he also used this 5%, 2% for the margin of error. His prevalence is greater than 10. So why not 5%? So it is enough for me. Thank you.
Thank you very much, Driba. Thank you very much. So I think till Dr. Ndale is back, let me continue, and I'll give the chance for the rest of you. So from my side, I was having difficulty really grasping the rationale of the study. It doesn't seem very strong. At some point, you were trying to show that the finding is going to be generalizable for entire private hospitals, at least in Addis, but that's not the case, because you purposely went to one hospital, one surgical center, and you conducted the study. So this is not representative enough to generalize it to other private hospitals in Addis. And on the conclusion part, you were trying to say that it will give us, this research result will give us an insight in terms of comparing the prevalence of complication between private and public hospitals. But again, your study is homogeneous. You only included patients from private hospitals. So you cannot talk about whether the result is better or not as compared to public hospitals, since your study did not include that. So I think when you submit your manuscript for a publication, you should go through the rationale of the study very well and make it something convincing. Otherwise, I don't believe it's a novel research, and I don't believe the studied population is unique enough for generalizability, comprehensive enough for generalizability. So please go through that. The other is on your introduction part. It's a bit bulky, just a general formatting issue. If you're submitting, if you submit it for a journal, they will definitely say that your introduction is a lot. Even on your presentation, it was a lot. So you have to make sure that it's condensed and reflects only the important parts of the introduction and literature review. You know, there is, when you submit your article, most journals restrict the word limits up to like 3,000, even in some journals 2,500 word limit for the entire manuscript. So you don't want to waste all of those on your introduction. You have to make sure to condense your research literature sentences and few and convincing sentences. So as for the study setting, why you chose only one hospital, again, that is not justifiable. You must come up with a better explanation. And for the study design, he said he used a retrospective cross-sectional design. Are you comfortable with a retrospective cross-sectional design? Is everyone okay with the design? If you have ever attended any of our research presentation webinars before, we have clearly mentioned that cross-sectional, as its name indicates, there is no such thing as retrospective or prospective cross-sectional design, because a cross-sectional design is a cross-sectional design, a one-time study, and it doesn't have any follow-up nature. So there is no retrospective or prospective. If it is a case control study, by default, it's retrospective in nature. because we go back and we try to see the patients by starting from their outcome into their exposure history. And what we have as retrospective and prospective is a cohort study design. So what you did is more of a retrospective chart review. So that's the proper study design that you used actually. The problem is you labeled it in a wrong study design name. So please correct it into retrospective chart review or record review study, because that's the proper design that you have used. For the exclusion criteria, you mentioned that patients admitted with the diagnosis of goiter but did not undergo thyroidectomy are excluded. I think this is already something that we know. You say you were talking about thyroidectomy complications, so we don't expect someone who did not go through the surgery to be a part of the population. That's clear from the title, from your objective, and from everything. So there is no need to mention something that doesn't even exist as a population for our study. The other is you have excluded patients with previous neck surgery other than goiter, previous parathyroid disease, history of dysphonia, and chronic kidney disease. What's the justification for this? I mean, some of the things are actually can be considered as one variable of your study. So what's the rationale for excluding these cases? For the sample size, normally, to begin with, as we said, your study design is retrospective chart review. So if that's the case, and if you want to calculate the prevalence, and if you did a single population proportion, if you use a single population proportion formula to calculate your sample size for the descriptive objective, which is to find the prevalence of early thyroidectomy complications, that's okay. But you have an inferential objective as well, which is to identify factors associated with the complications, right? So you're expected to have to calculate a double population proportion formula and identify the sample size for the inferential objective, but you didn't do that. But most importantly, the recommendation for retrospective chart review studies, since the data is already collected, since it's already there, and since you're not making anybody go through a new process to collect the data, the recommendation is to review every available data unless cost is an issue. So I think at the end of the day, what you did is like you included everyone. So you can justify, you can say that we have included everyone during the study period, if the study period that you have selected is, again, justifiable. Why only that period? Why not longer? Why not shorter? Why did you choose just that period of time? What was the rationale? And in cases where you take every sample from during the observation period, you are expected to do what we call a post-hoc power analysis to show that your study was adequately powered, even if you did not do a prior sample size calculation. So I don't know how many of you are familiar with this. So is there anybody who's familiar with post-hoc power analysis concept? Anybody? So in cases when, thank you, Kabrisfal, that's wonderful. So what do you understand by that? Let me give you the chance. Kabrisfal, you can unmute your mic and you can explain. Okay, maybe you can explain later. So post-hoc power analysis is in studies where, like in most of clinical research, what we do is we do chart reviews, right? As an intern, as a resident, as a fellow, we usually tend to collect our information from the charts, not directly from the patients, not a primary data. So in those cases, we take all the cases because to begin with, most of the charts might not be available and there are few cases in that respective subject. So what we should do is after we collect data from all patients, we have to make sure that our research is adequately powered given the total sample size that we have obtained from the available record and the results that we have obtained. I think we can make this, okay, sure, you can write your answer in on the chat box. Thank you, Kabrisfal. So that is something that you can do. So instead of just trying to calculate sample size, you can go for that. On the analysis plan, can you please display the slide on the analysis plan? Dr. Tasfa, it's very important. There seems to be somehow a confusion in that area. The first thing is whenever we do analysis, on analysis part. Yeah, the next slide, please. Yes. Here, yeah, I have to be honest, this is a very confusing part. Univariable analysis. What do you understand by univariable analysis? Here, what you're trying to describe is what you did for data description or summarization for your study. So you said you have used categorical variables for frequency for categorical variables, mean or median as necessary for numeric variables. But you are mentioning univariable analysis. This is not the place for a descriptive analysis. So whenever we have data, what we do is the first thing we describe the data. Describe the data means we state how many patients we included, how many of them were male, how many of them were in some age category, how many of them were from Addis, or how many of them have these symptoms, and how many developed complications. And these types of descriptions in terms of their socio-demographic and clinical characteristics, we describe the participants. So to describe the participants, we use, as you stated clearly, with frequency, percentage, mean, median, and other summary tools. So the second thing we do is, if our study is comparative type of study, if there are comparator groups like in a cohort or in a case control design, what we do is we compare our groups to make sure that they're comparable. They don't have significant difference in their characteristics. So in those cases, we use chi-square, t-test, ANOVA, and other non-parametric tests to see if the groups are comparable or not. And the third stage is, for your study, you don't need chi-square and other tests because it's not a comparative study. It's just a retrospective chart review study with one group. There is no classification, so you don't need this part. So the third part of analysis that we do is, or the second part in your case, is regression analysis. So when we do regression analysis, there are steps that we use, that we go through. The first one is, after we select the proper regression analysis model, we try to select the variables in terms of their association with the dependent variable. We do one-to-one analysis, and we call that one-to-one analysis univariate or bivariate. So univariate and bivariate are basically the same thing. So univariate or bivariate analysis is done to see if each and every one of our independent variables or exposures are linked or associated to the outcome variable at some cutoff point. And the cutoff point that we use for univariate and bivariate analysis usually is 25% or sometimes 20%. In rare cases, if we want to be very strict, we can use 10% as well. But what we commonly use is the 25%. So your p-value should be less than 0.25. But you have stated that the p-value that you have used is 0.05, which is wrong. If you use 0.05 for the bivariate, it will be very difficult to get significant variables to be fitted into the final model. So after you do your bivariate or univariate analysis, the last thing that comes is multivariable analysis. Thank you for stating it properly. Most people usually present it as multivariate analysis. So the correct terminology is multivariable analysis. So for the multivariable analysis, we use a p-value of 0.05 as a cutoff point to declare if a variable is significant or not. So in multivariable analysis, what we include in our model is all variables that were found to be significant from the univariate or bivariate analysis, which is at 25% level of significance. Then we might have like 5, 6, or 10 variables to be included in the final model. The multivariable model, not multivariate. So on the multivariable model, variables with p-value of less than 0.05 will be declared as significantly associated with our outcome, which is early post-thyroidectomy complications. So these are the process, but what you wrote is a bit confusing, especially when you state, as the Riba said, you said you have used chi-square. There is no place of chi-square. You run both the univariate or bivariate and the multivariable analysis using the same regression model. We don't run one-to-one analysis using chi-square test. Chi-square test has a different purpose and it should be used where it should be used. It doesn't have any role here. Here you have to use the proper regression analysis model that you have picked, which is the binary logistic regression model. So the other is you have mentioned that you have assessed the strength of association using Phi and Kramer's v-test. These are not relevant for your research at all. And for the multicollinearity result, you have stated that some of the results were like above 0.01 or something like that. VI values are not like that. I don't believe you have picked the proper statistical results from your regression analysis from the SPSS output. You have to go back and revise it, because for the multicollinearity test, what you get is the VIF result, which is not within that kind of range of number. Please revise those parts. And the final fitness of the model, you said it was checked using so many, like you said, omnibus test. I don't know, you said a lot of things. And one regression model has its own way of testing its assumption and its own way of testing the adequacy of the final model. But in your case, you have tried to mention everything which is not realistic and which is not acceptable, which is not something that you can do within that regression analysis. So for binary logistic regression, what you can do is post-MRL model fitness test, and that's the only thing we expect you to present. So please revisit your statistical analysis part again and do the analysis again. On the ethical clearance part, it's important. You said after obtaining permission and clearance from my advisor in the school. Your advisor is there to help you, but has got nothing to do with issuing ethical clearance. Yeah, we all know that whether you're a student or not, we all have some supervisor when we do research to help us get in the right direction, but doesn't have anything to do with ethical clearance, and it should be removed. And Addis Ababa Regional Health Bureau just does not give you the permission. Rather, the Regional Health Bureau has its own ethics committee, and they're expected to give you IRB. So you have to present that clearly. The sentence is not strong, and you have to make sure that it's strong and convincing by someone who reads it. And you should show that you have actually obtained the proper ethical clearances for your research from the appropriate bodies. On the result parts, you have been, the first thing that you have presented is that, let me share it with the audience, and I'd like to get their opinion. Look at this on the chat box. So you say the most frequent thyroid surgery was total thyroidectomy, and the most common presenting symptom for thyroid surgery was anterior neck swelling and others. So what was the objective of the research? I want to know, not from you, but the audience. Can you please write the objective of his research? What were the objectives of his research? You can drop it on the chat box. If you have followed his presentation very well, you'll be able to pick the proper objectives for his study. So prevalence of post-op complication and associated factor, right? So the first thing is you want to measure the prevalence of post-op complications, great. And the second thing is he wants to see what were the factors that are associated with increased odds of early thyroidectomy complications, right? So, but most of your result and discussion part focused on describing and narrating and comparing the descriptive part of your research, which is the characterization of the study population and the type of the surgical method and other things. You know, your audience wants to see what you have obtained on those two objectives, not about the other things. You're expected to present those things to characterize your population, but you have to focus and bring out your two main results, which is the prevalence of post-thyroidectomy complications and the associated factors, more than any of the other results. But you have been consumed and presenting the other non-relevant part of your outcome. And at some point, I was personally lost, and I couldn't keep track of the results. So please make sure to keep your result section concise and make it focus on the main objectives of your research. And the other is for age, you presented it in one place, you presented it with as mean, and in the other place as median. So what was the rationale for presenting it like alternatively, in one place like with mean, in another place like with median? Are you comfortable with this? Anybody? Is it okay to present your result both as median and mean? Kibris found no, right? Why? Because mean and median, these are tools that should be used in the appropriate scenario. So if your data has a normal distribution, you are expected to use mean. It's not about choosing to use mean. You have to use mean. It's indicated. But if your data has a skewed distribution, then you are expected to summarize your result using median. So if you use median, you are also expected to present the interquartile range. If you use mean, you are expected to present the standard deviation together with the result. The other thing is, you have already, please display the table. You have already presented the results. You have age groups, right? So presenting one variable in different forms is going to add to the word limit of your study without just adding any relevance. So in one research, you have presented your study with median, the age variable with median, with mean, and with also category. So it's not relevant. Just focus on one of the most appropriate form of presenting your result and proceed with that. The most preferable is to use the category because it will tell us exactly which age group is more at risk or not, as compared to just a simple using it as a numeric variable. So stick with the categories and forget the others. And you say the average hospital stay was like 3 to 7 days, but for patients stayed longer. Again, this seems like something that you have written based on just your observation of the data presentation without using a statistical summarization tool. This is not acceptable. If you want to show the average hospital stay, first, just like the age, you have to check the distribution of the length of stay, whether it's normally distributed or skewed. If it is normally distributed, you have to present it with mean and standard deviation. If it's skewed, with median and interquartile range. What you have presented is not acceptable and is not a proper way of summarizing your result. And you have a lot of small frequencies on your table. Please put it on the regression table. On the regression table. Yeah. Yeah, as you can see, you have a lot of small frequencies in most of your variables, and because of that, you have wide confidence interval results, as you can see, right? So you were trying to explain the result, why it was wide. What we need is not the justification why it's wide. We all know that it's wide because the category has a small frequency, and we know that if there is a small frequency in any set, especially for odds ratio calculation, because of the nature of the formula, you're going to end up with wide confidence interval result, which is not acceptable. What you're supposed to do is not tell us why it happened. What you're supposed to do is manage your data so that a wide confidence interval result like this do not happen. So just please go back to the previous slide. Maybe the problem of the wide confidence interval on the follicular CA part is very visible because it is above 1, and we can see that it's from 1 point something up to 52. How about these? How about these results? Are they wide or not? Do you know how to interpret results, odds ratio values which are less than 1 for the audience? Are these wide or not? These two significant results for gender and thyroid lobectomy with this, they're wide. Faisal, they're wide, right? Why did you say it's wide? Does everybody agree? Is it wide? Within 10%, great. So to avoid these confusions, we usually actually should interpret our results in terms of percent when it's below 1, because it might be tricky and we might not see these wide confidence intervals when it is below 1. So if you change it into percent, how much is it going to be? The result for example, for age, if you know how to change it into percent. So this is the result. Change it into percentage. Faisal 9 to 73. Do you agree? Do you agree? When we change odds ratio or relative risk values from which are less than 1 into a percent, what we're supposed to do is subtract the result from 1. So we are expected to subtract 0.26 from 1. So Faisal, what you're supposed to do is subtract all of the 3 numbers, the confidence intervals, and the adjusted value from 1 and multiply it by 100%. So you will get the percentage. Either way, these are very wide numbers and they're not acceptable. Your data needs like a very good data management. You have to go through it again. Make sure to merge all your categories. You know, let me tell you how sensitive it is. If you have a patient with a trauma patient, and if the patient is bleeding, you can stand there and explain why the patient is bleeding, right? But what you're expected to do is manage the patient so that the patient stops bleeding, right? So now you're telling us why the problem happened. We're not interested in knowing that. Even if it's statistics, like we usually overlook these statistical gaps and we publish our articles with all their problems. But we're supposed to show how important it is to manage our problem and present a data that's acceptable. And when it's interpreted, it gives meaning. It can be generalizable. It can be used as part of evidence for further reviews and other evidence synthesis. So please make sure to manage your data. And I appreciate the fact that you picked that there is a problem and you also know why the problem happened. So the next thing is to manage that. So please manage that. Most of the things, like I said, a bit confusing. Especially on the discussion part, you focused on characterizing the study population and discussing what the characteristics is as compared to other research. We don't want that. You have 2 main objectives, the prevalence and the associated factors. Just compare those results with previous research and justify that in the context of the scientific knowledge that we have so far, in the context of the local practice, the policy, the national guidelines, and tell us if the result that you have obtained is, what does it mean? What's the meaning of your result? But I did not see that part at all. And on the strength of your study, on the limitation of your study, you say that you were not able to see long-term outcomes because of loss of data. To begin with, you were interested in measuring, assessing early post-thyroidectomy complications. So why bother talk about long-term outcomes? You're not interested about that. You are just putting a limitation on your study, which is not a limitation at all. And you are just making your paper look weaker. So avoid things that doesn't have any implication for your paper, because it will backfire at you and will make it difficult to get it published. And about this, I'd like to give the chance for the audience. How do you interpret this? Please see the chat box, and what's your take from this? For the clinicians, I'd really like for you to reflect on this, especially if there are surgeons. I saw some surgeons earlier. If you guys are still in the meeting, can you please reflect on this? What does it mean for you or for the hospital? Anybody? I want you to, okay. Beyond the methodological issues, how does it reflect on the care that we provide? Right? It's not just from the methodological parts. It reflects partly on the system and on our practice. I want you to take a look at it very well. And saying this, since you're expected to go through the entire research result analysis and discussion. And you have to revise your conclusion recommendation accordingly. Your conclusion is not properly written. Besides, you have compared the finding with a public hospital, which you did not include in your study and which you cannot talk about. And the recommendations are not totally result driven. So after you go through the result sections again, you have to revise those sections. I think for the sake of time, I'd rather skip the other comments. I have focused on the major ones. And let me give the chance for the audience. That's why you can also read the comments. The audience is dropping on the chat box.
Yes, I'm reading them.
Yeah. Oh, okay. Dr. Ndala, glad to have you back. Please, you can continue. I didn't see you join back. Thank you.
Okay, I've joined after some 10 minutes. It was a very
Okay.
bad network.
Okay.
My
now
first
it's very
comment.
much-
Okay, my first comment. He used prevalence of complication of 11.5% from a study done in Gondar to calculate the sample size. But the same research said that 71.5% of patients do not have follow-up after discharge. That means some of the patients who have developed complication never appear to that hospital again. That means the study has already underestimated the prevalence of complication. And this study has used as a reference 11.5% prevalence of complication, which may also underestimate the real prevalence of thyroid complications. The second point I want to raise is in the types of surgical procedure for thyroid. One of the surgical procedure, what he mentioned as partial thyroidectomy, is not a standard description. There is nothing called partial thyroidectomy because near total thyroidectomy, lobectomy, or lobectomy with isthmusectomy, all these are types of partial thyroidectomies. So I don't know what does it mean, partial thyroidectomy. In standard definition, we don't have this kind of terminology. The other point, when we want to categorize type of surgeries, it is better to put this procedure into three main groups. One is subtotal thyroidectomy, which means something is done on both sides of the thyroid lobes. The second is what you call aggressive surgery, total or near total thyroidectomy of the thyroid gland, which can be written as lobectomy or lobectomy with isthmusectomy, or it can also be written as hemithyroidectomy. Okay, the classification should be in this type. The other comment, hypothyroidism, 38.1% complication. When I think of especially total and near total thyroidectomy, I don't consider hypothyroidism as a complication. Hello? Hello?
I can hear you.
We can hear you, Dr. Ndala.
Hello? Hello?
Can you hear him? That's fine.
Yes, I can hear
Hello?
you. Yes, I can hear him.
Yeah, we can hear you, doctor.
Hello? Hello?
Yes, Samal, Dr. Ndala, you can proceed.
Hello? Hello? Okay. So hypothyroidism, when someone is doing total or near total thyroidectomy, the plan is to, okay, are you hearing me?
Yes, I'm hearing you.
Yeah, I have already planned. Okay, I have already planned to remove the whole thyroid tissue. This is the expected outcome after total or near total thyroidectomy. Hello.
We can hear you, Dr. Dala.
Yes, hypothyroidism is not a measure of is not a measure of total. I mean total or near total thyroidectomy. So that one should be interpreted very carefully. The other thing, hypocalcemia prevalence of 4.3%. How was this defined? Biochemical or clinical? The other thing, the real definition of hypocalcemia following thyroid surgery, one has to follow the patient for at least 5 days, because first day, second day, third day, patient can be okay, and hypocalcemia can occur 3 and 4 or 5 days after the day of surgery. The other thing, superior large nerve injury of 2.9% in 8 patients. How was that diagnosed? Is that clinical or laryngoscopic examination? This also needs, clarification. And the other point, very important point, is that the study evaluated 345 patients, cards, who were admitted under the diagnosis name of goiter. Okay? Many patients who have undergone thyroid surgery, they are admitted under the diagnosis of thyroid cancer, not goiter. They can also be admitted as thyrotoxicosis. They can also be admitted as Graves without mentioning any of the word called goiter. So how were these patients considered? Did you miss all these patients, or have you checked for these possibilities also? The other point, in the exclusion criteria, you excluded patients with previous neck surgery. Previous neck surgery, but you have also included patients with previous thyroid surgeries, okay? When you exclude patients with previous surgery, non-thyroid type, the aim is that the previous surgery may have an impact on the current thyroid surgery, but the previous thyroid surgery can also have the same effect on the current thyroid surgery. I think if you exclude or if you include, you can include all, because the effect of previous thyroid surgery and the effect of previous tracheal or esophageal surgery on the neck more or less is similar on the risk of complication on the current surgery. And the other thing, probably that may not be really related to your presentation, when you get a report of total thyroidectomy, is that really total? Because from my clinical practice, I have seen that many patients reported as having total thyroidectomy finally will have significant amount of thyroid tissue remaining behind. So this may also affect the relationship between the type of thyroid surgery and the prevalence of thyroid complications. And these are some of the points I have. And sorry, one last point. Post-operative pathology, you said the most common is colloid goiter, followed by multinodular goiter, okay? Here you are mixing up two different things, okay? Colloid is a pathologic diagnosis. Multinodular goiter is not a report that we need from the pathologist. This is a report you can get by doing physical examination or by doing ultrasound examination, okay? So it's just like number one is, just putting a list of people's weight and height, which has nothing to compare, okay? So the second is not a pathological report. It should be a clinical. Actually, it's not your fault. I know some pathologists report like this one, and it should never happen, because this physical examination, the other is a report from find the respiration or pathologic examination of a thyroidectomy specimen, okay? These are some of the pointers. Thank you.
Thank you very much, Dr. Ndala. We're glad you were able to join back. You would have missed all of these important insights. That's why please take a few minutes and reflect on whatever you find relevant to reflect on. Just before that, one thing, please check the chat box. One of your findings is thyroid lobectomy with this vasectomy is associated with lower risk of complication. So what's your recommendation based on this? I saved this because I thought Dr. Ndala didn't join back. So what can we recommend based on this result?
Based on this result, it could be recommended that such type of procedure has associated better outcomes compared to other procedures, but most of the procedures are individual specific. It's surgeon specific surgical procedures, and I'm just presenting the data from what they've done and the outcomes that they have found.
Yeah, you're right. Yeah, you have collected the data that you have found, but based on these data, the type of surgery has effect on the odds of developing complication, right?
Yeah.
So what do you recommend based on this? The audience can also reflect on that. So what can we recommend based on this? Oh, sure, Dr. Ndala, please.
Actually, this report, very difficult to get a recommendation from this report because we should take three things into consideration, okay? The type of pathology the patient has, the type of surgery, and the experience of the patient, okay? The experience of the surgeon. The three things should be taken into consideration, okay? Otherwise, any recommendation from this finding becomes very difficult. If you say, for example, lobectomy is better than total thyroidectomy, for a patient with thyroid cancer, that's going to be very dangerous. Okay. And in the hands of well-experienced thyroid or endocrine surgeon, the outcome of total thyroidectomy complication rate is not much different from lobectomy. There is some difference, but still the total thyroidectomy becomes a safe procedure. So making a recommendation becomes somewhat very dangerous. I would say is not enough to recommend.
Right? Yeah, I mean, when it comes to choice of surgical procedure, which are actually based on scientific indications, and when we find significant difference on those areas,
Hello?
what are we going to recommend
Hello?
based on that? It's audible, Dr. Ndala. Can you hear me? That's why can you hear
Hello?
me?
Yes, I can hear you. Yes.
Hello?
So we can hear you, Dr. Ndala.
Missed again.
Okay. So whenever we pick our variables, we have to be careful. If we get a significant effect of that variable. Hello, Dr. Ndala. We can hear you.
Yeah. Can I comment on this? It's
Sure.
really difficult for me, especially as a general practitioner, to recommend a surgical procedure. But what I'm trying to present is based on the type of procedures they did, the one with the least post-thyroidectomy outcome, complication outcome was this procedure. But I think, as Dr. Ndala was trying to say, the procedure is patient-specific as well as experience-specific. And I think so. Inferring and suggesting this kind of procedure for this patient should be, I think this is difficult for me as a general practitioner.
Oh, yeah. By the way, yeah, you can be a general practitioner, but you have been through all the, I don't know, the medical experience in all fields, and you can get someone with working in that field on board. That's why the whole point of this session is also to show that when we do clinical research, we need collaboration. We need the insight of the clinicians, not only the researchers. So that is relevant, but your answer shouldn't be, I'm just a general practitioner and I can't say a lot about this. As long as you're studying on one subject, you have to master that, read that, or get someone on board and have a clear recommendation and have a clear conclusion of your results. That's what I wanted to say. So please don't answer like that for the future, okay? No, are you going to say this for the reviewer? I mean, when you submit it for a journal, if someone asks this question, you're not going to, I'm a general practitioner, so okay, take your paper and don't come back. That's what they're going to say, okay? So get someone on board, do the analysis again, and provide revise the results and the discussion, everything that follows, okay?
Thanks.
It's a very important implication. I think Dr. Ndala couldn't join. Okay, he joined back. So if he has something to add, he can add. So please take 2 to 5 minutes and reflect on
Okay.
the questions. Okay,
Okay.
that's fine.
Yes, yes, okay. Shall I
Okay,
continue?
if you have anything or not,
Okay. Concerning your limited surgery, okay? Hello? Hello?
we can hear you, Dr. Ndala.
Okay. Concerning the recommendation of lobectomy with lower complication, okay? Statistically, you may get something significant association, you may recommend. But when it comes to clinical, it becomes somewhat different. There is a section from patient's recurrence, what you call experience of the patient. Okay, even the details of the pathology is not well. For example, the size of the tumor, the size of the specimen removed is not seen in any of the data. Okay, these things also affect the type of surgery that we have to do. Okay? Statistically significant, but clinically one has to see it in a different way. Okay. Otherwise, we always advise for our patients, for our residents, what we do as total thyroidectomy, we advise them to do near total thyroidectomy or subtotal. Even if the pathology is the same, experience matters to reduce the risk of complications. One has to modify the type of surgery he's doing. Okay? Otherwise, by looking at the statistical association, one cannot say lobectomy or limited surgery always has a superior outcome than total thyroidectomy. Okay, thank you.
Thank you, Dr. Ndala. I think, Dr. Tesfaye, you've got most of the comments.
Yes.
I think you can work on those things.
Yeah.
መጨረሻውን ያወራሁት ኪሳራ ይሰሙኝ አይደለም አይገርም ሙሉ ወጥ
We can hear you, Dr. Ndala.
We can hear you, Dr. Ndala. We have
okay. Sorry.
we have listened to all of the comments. Thank you very much. So I have dropped the link to the post test. If anybody, just for the sake of time, so if you have any other suggestions for him, I think we can keep it on for a while. Dr. Ndala, I think we can excuse you to leave the meeting. Now it's time for them to go through the post test. Thank you everyone for attending the webinar. Thank you, Dr. Tesfaye, for your nice presentation.
Thank you.